Chapter 5 Developmental Disorders. Ankyloglossia. Cause developmental. Location tongue and floor of the mouth. Clinically, it appears as a complete or partial fusion of the lingual frenum of the tongue to the floor of the mouth or lingual gingiva of mandible incisors. The treatment is the surgical removal of a portion of the lingual frenum and can be diagnosed clinically. Commissural lip pits. Cause is developmental. The location is the commissure of the lips, corners of the mouth. Clinical features include tiny blind tracts that present at the corner of the lips. There is no treatment and can be diagnosed clinically. Lingual thyroid. The cause is developmental. The location is the posterior dorsal to the tongue. Clinical features include a mass of tissue at the midline posterior to the circumvallate papilla. The microscopic features are normal thyroid tissue, and the treatment is usually none, may be the individual's only functioning thyroid tissue, and removal may be indicated if the mass is too large. The diagnosis is usually done clinically and in the laboratory to identify thyroid tissue. Dentigerous cyst. The cause is developmental and appears in young adults. The location is around the crown of an unerupted, impacted, or developing tooth, and clinically, if it's larger, can displace teeth. Radiographically is a well-defined unilocular radiolucency. Microscopically, the cyst lined by cuboidal to squamous epithelium. The treatment is removing the cyst and associated tooth and can be diagnosed radiographically and microscopically. Eruption cyst. The cause is developmental and appears in children. The location is soft tissue around the crown of an erupting tooth. Clinical features include swelling at the site of erupting tooth. Microscopically, the cyst lined by a cuboidal to squamous epithelium. The treatment is usually none. Tooth erupts through the cyst, and diagnosis process includes radiographically and microscopically. Primordial cyst. Cause is developmental. It appears in young adults, develops in place of the tooth, and the mandibular third molar area is the most common site. The clinical features are asymptomatic. Radiographically, it's a well-defined radiolucency. Microscopically, the cyst lined by the cuboidal to squamous epithelium, and the treatment is surgical removal of the cyst and can be diagnosed radiographically. Odontogenic keratocyst. Its cause is developmental and is most commonly found in adults aging between 20 and 30 years old. It's found on the posterior mandible, which is the most common site, and if it's too large, it may expand the buccal tissue. Radiographically, it's a well-defined, usually multilocular radiolucency. The microscopic features is a cyst lined by a thin corrugated parakeratonic squamous epithelium that is 8 to 10 cell layers thick. The treatment is surgical removal of the cyst with peripheral osseous cartilage, and it can be diagnosed clinically. Lateral periodontal cyst and the botryoid cyst. This is also caused by developmental issues, and it affects men more than women. The median age is 50 to 60 years old. The location is the lateral aspect of tooth root, the mandibular cuspid premolar area. The clinical features are asymptomatic. Radiographically, the LPC has a unilocular radiolucency, while the BC has multilocular radiolucency. Microscopically, the cyst is lined by a non-keratinized squamous epithelium with focal thickening. The treatment is surgical removal, and it can be diagnosed microscopically and radiographically. Gingival cyst. This is also developmental, and the median age is 50 to 60 years old. Soft tissue of the mandibular cuspid premolar area is where it's found, and clinically there's a bulge or swelling of attached gingiva or interdental papilla. Microscopically, the cyst is lined by a thin, non-keratinized squamous epithelium that may have focal thickening. The treatment is surgical removal, and the diagnosis process is clinical and microscopic. Glandular odontogenic cyst. Cause developmental. Median age is 40 to 50 years old and is most commonly in the anterior maxilla and posterior mandible area. Clinically, it may cause enlargement of the bone, and radiographically appears as a unilocular or multilocular radiolucency. Microscopically, the microscopic cyst lined by cuboidal columnar epithelium with microcysts and focal thickening. The treatment is surgical, and the diagnosis process is radiographic and also microscopic. Nasopalatine canal cyst. The cause is developmental and affects men more than it does women, and the common age is 40 to 60 years old. It's located on the anterior maxilla, the nasopalatine canal, and also the incisive papilla. Clinically, it's asymptomatic, but it can appear as a pink bulge at the incisive papilla area. Radiographically, it's a well-circumscribed radiolucency between the maxillary central incisors and is an open heart shape. Microscopically, the cyst is lined by a squamous or respiratory epithelium and the blood vessels and small nerves in cyst wall. The treatment is surgical and it can be diagnosed radiographically as well as microscopically. Median palatine cyst. The cause is developmental and its location is the midline of the hard palate posterior to the palatine papilla. If it's large, there's a swelling at the midline of the hard palate, and radiographically it appears as a unilocular radiolucency. Microscopically, the cyst is lined by a stratified squamous epithelium surrounded by dense fibrous connective tissue. The treatment is surgical, and the diagnosis process includes both radiographic and microscopic. Globulomaxillary cyst. The cause of this is unclear, but it's located between the maxillary lateral incisor and cuspid. The clinical features are asymptomatic, and radiographically it appears as a pear-shaped radiolucency. Microscopically, the cyst lining varies from squamous to cuboidal to respiratory epithelium. The treatment is surgical, and the diagnostic process is radiographic and microscopic. Median mandibular cyst. The cause is unknown, and the location is the midline of the mandible. Clinical features are asymptomatic, but if very large may cause expansion of lingual aspect of the mandible. Radiographically, it's a well-circumscribed radiolucency below the apices of the mandibular incisors, and microscopic features include a cyst lined by squamous epithelium. The treatment is surgical, and the diagnostic process is radiographic and microscopic. Nasolabial cyst. The cause is developmental, and the ratio of women to men is 4:1 and is found in adults aging from 40 to 50 years old. The location is the soft tissue of the face, nasolabial fold area, which is the maxillary canine floor of the nose area. Clinical features include expansion or swelling at the nasolabial fold area or mucobuccal fold area. Microscopically, the cyst is lined by respiratory epithelium. The removal is surgical, and the diagnostic process is clinical and microscopic. Cervical lymphoepithelial cyst and intraoral lymphoepithelial cyst. The cause is developmental epithelium. The location is the lateral neck at the anterior border of the sternocleidomastoid muscle. Intraorally, the lateral border of the posterior tongue and the floor of the mouth. Clinical features include a brachial cyst appearing as a bulbous area on the lateral neck. Intraorally, it's a pink, yellow, well-delined raised nodule. Microscopically, the cyst is lined by a stratified squamous epithelium surrounded by lymphoid tissue. The treatment is surgical removal, and the diagnostic process is microscopic. Epidermal cyst. The cause is epithelium of hair follicle. The location is the skin of the face and neck, and the clinical features include a localized firm movable swelling. Microscopically, the cyst lined by keratinized stratified squamous epithelium and the lumen filled with keratin scales. The treatment is surgical removal, and the diagnostic process is microscopic. Dermoid cyst. Cause developmental and is present at birth or in young children. The location is the anterior floor of the mouth. If it's large, it can displace the tongue, and it's a dough-like consistency. Microscopically, the cyst is lined by a stratified squamous epithelium surrounded by connective tissue wall, hair follicles, and glands seen in the cyst wall. The treatment is surgical removal, and the diagnostic process is microscopic. Thyroglossal tract cyst. The cause is developmental and is usually diagnosed at 20 years of age. The location along the thyroglossal tract from the foramen cecum at the normal location of the thyroid gland below the hyoid bone. Clinically, if below the hyoid bone, the bulge of the swelling in the midline of the neck, and microscopically, the cyst is lined by epithelial thyroid tissue in connective tissue walls of the cyst. The treatment is surgical removal and complete excision of the cyst and tract, and the diagnostic process is microscopic. Static bone cyst. The cause is developmental depression of the lingual aspect of the posterior mandible and can be unilateral or bilateral. It's more common in men, and the location is anterior to the angle of the ramus and inferior to the mandible canal. The clinical features are asymptomatic, but radiographically it can be seen as a well-circumscribed radiolucency in the mandible area below the inferior alveolar canal. The microscopic features are not a true cyst, and the normal salivary gland tissue is found within depression. The treatment, there is no treatment, and the diagnostic process is radiographic. Simple bone cyst. The cause is unclear, although trauma is suggested as a possible cause, and the age range is teenagers to young adults. It's located on the mandible and is usually asymptomatic, occasionally enlarging the bone. Radiographically, there's a radiolucency and characteristic scalping around the roots of teeth. It's not a true cyst, but the space in bone is not lined by epithelium, and the treatment is surgical intervention, and the diagnostic process is also surgical. Aneurysmal bone cyst. The cause is unclear, but it's often associated with other bone lesions. It affects more women than it does men, and it often occurs in people under the age of 30. It's located on the posterior maxilla or mandible, and clinically it causes expansion of involved bone. Radiographically, multilocular radiolucencies or honeycomb or soap bubble appearance. It's not a true cyst, but appears as a blood-filled space surrounded by multinucleated giant cells and cellular connective tissue. Treatment is surgical removal and supplemental chirotherapy, and the diagnostic process is microscopic. Anodontia. The cause, developmental, and its location is throughout the arches. Clinically, it appears as an absence of all primary or permanent teeth. Radiographically, all teeth are absent. The treatment is prosthetic replacement of the missing teeth, and it can be diagnosed clinically and radiographically. Hypodontia, developmental. It's located on the maxillary third molars, the mandibular third molars, the maxillary lateral incisors, and the mandibular second premolars. Clinical features is the absence of one or more teeth, and radiographically is also the absence of one or more teeth. The treatment is a prosthetic replacement of the missing teeth and can be diagnosed clinically and radiographically. Supernumerary teeth. Cause, developmental, and the location is more often in the maxilla over the mandible. The clinical features include a presence of one or more extra teeth, usually smaller than normal, may be erupted or unerupted. Radiographically, it's seen as one or more extra teeth. The treatment is usually extraction if it's necessary, and it can be diagnosed clinically and radiographically. Mesiodens. The cause, developmental. Location is near or at the midline between maxillary and central incisors. Clinically, the most common extra tooth may be erupted or unerupted or impacted, and it usually appears conical and small. Radiographically, the extra tooth is seen at the midline of the anterior maxilla, and the treatment is extraction or no treatment, and diagnostics include clinical and radiographic. Distal molar. Cause is developmental. Location is distal to the third molars. The second most common supernumerary tooth may be erupted, appears small, or impacted. Radiographically, extra tooth distal to the third molar. The treatment is no treatment or extraction, and diagnostic processes include clinical and radiographic. Microdontia. Cause, developmental. Location, maxillary lateral incisors. Peg laterals is the most common. Maxillary third molars. Clinical features include affected tooth appears smaller than normal. One or more teeth may be affected. Radiographically, the tooth is smaller than normal. Treatment, if unerupted, restore and reassemble the tooth to normal size, and it can be diagnosed clinically or radiographically. Macrodontia. Cause, developmental. Location, any tooth. Clinically, the affected tooth appears larger than normal. One or more teeth may be affected. Radiographically, the tooth appears larger than normal. There is no treatment, and diagnostically, it can be diagnosed clinically or radiographically. Germination. Cause, developmental, and it affects primary teeth more than permanent and anterior teeth more than posterior. The tooth appears larger than normal. The large crown appears bifid, and normal number of teeth are present. Radiographically, it appears as a single tooth with a bifid crown and one common root canal. Treatment, if aesthetic problems, alteration of the tooth to reassemble normal-sized tooth. Diagnosis includes clinical or radiographic. Fusion. Cause, developmental. Affecting primary teeth more than permanent and anterior teeth more than posterior, is most commonly found on the incisors. Adjacent teeth are fused together and a large crown is seen. Radiographically, it appears as a single large crown with the separate or fused roots and root canals. Treatment: if aesthetic problems, alteration of tooth to reassemble normal sized tooth, and it can be diagnosed clinically and radiographically. Concrescence. Cause: developmental. Location: maxillary molars. It can't be observed clinically, but radiographically it appears through the root of adjacent teeth are connected. There is no treatment and is diagnosed radiographically. Dilacration. Cause: developmental. Location: any tooth. Cannot be observed clinically, but appears as a sharp bend in the tooth root. There is no treatment and it can be observed radiographically. Enamel pearl. Cause: developmental. Location: maxillary molars in the furcation area. Cannot be observed clinically, but radiographically it appears as a small sphere of enamel at the tooth root. There is no treatment and it can be diagnosed radiographically. Talon cusp. Cause: developmental. Location: incisors. The crown appears normal facially. An accessory cusp is located at the area of the cingulum. Radiographically, it appears as a tooth with abnormally short roots and a low furcation area. The pulp chamber is abnormally large. Treatment: removal of the cusp and restoration of the tooth if the cusp interferes with occlusion, and it can be diagnosed clinically. Taurodontism. Cause: developmental. Location: the molars. Cannot be observed clinically because the crowns appear normal. Radiographically, however, the pulp chamber is enlarged and elongated. Roots are shorter with the furcation near the apices. Treatment: there is no treatment and it can be diagnosed radiographically. Denzin dente. Cause: developmental. Location: anterior over posterior. Maxillary and mandibular incisors. Maxillary lateral incisors. Clinical features: appears as a tooth may appear normal or peg-shaped. Radiographically, enamel invagination noted with crown of involved tooth. The treatment: if the tooth is vital, placement of a prophylactic restoration; if non-vital, root canal therapy. It can be diagnosed clinically and radiographically. Dens invaginatus. Cause: developmental. Location: mandibular premolars, molars, cuspids, and incisors. Clinical features include accessory enamel cusps seen on the occlusal surface. Radiographically, may see pulp horn extension in accessory cusp. There is no treatment and can be diagnosed clinically. Supernumerary roots. Cause: developmental. Location: maxillary and mandibular third molars, mandibular premolars, and cuspids. Cannot be observed clinically, but radiographically, visible extra roots. Treatment: there is no treatment and it can be diagnosed radiographically. Enamel hypocalcification, caused by trauma to the enamel during maturation phase. It can occur on any teeth. Crowns may have pitting, grooves, or staining, and crowns can have a chalk white spot on the middle third. If necessary, restorations can be placed to improve appearance and can be diagnosed clinically. Endogenous staining of teeth. It's caused by the ingestion of tetracycline or systemic disturbance during tooth development. It can occur on any teeth. With tetracycline staining, the crown appears yellow-green or brownish gray. If necessary, restorations can be used to improve the appearance and is diagnosed clinically. Regional odontodysplasia. Cause: developmental. Several teeth in the same quadrant are affected. Primary or permanent teeth, usually maxilla over mandible. Affected teeth do not erupt or eruption is incomplete. Radiographically, reduced radiodensity of involved teeth and teeth appear ghost-like with large pulp chambers and thin enamel. The treatment is usually extraction and can be diagnosed clinically and radiographically. Impacted teeth. Cause: developmental. Location: maxillary and mandibular third molars. Maxillary cuspids. The clinical feature is that the teeth just don't erupt. Radiographically, the teeth appear impacted and are surrounded by bone. The treatment is surgical removal and it can be diagnosed clinically and radiographically. Ankylosed teeth. Cause: developmental. Location: most commonly deciduous molars. Clinical features are a primary ankylosed tooth prevents the eruption of a permanent tooth. Radiographic features include ankylosed teeth do not exhibit a periodontal ligament space. The treatment is extraction and the diagnosis process is clinical and radiographic.